This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
Our very own Methods Core faculty, Julie Richards, to lead the Methods Core seminar today. So as you all know, Julie is a health services researcher who's dedicated to improving healthcare systems for individuals at high risk of suicide. And Julie's an associate investigator at Kaiser Permanente Washington Research Institute and is really dedicated to improving healthcare in partnership with the people who provide and receive healthcare in that setting. So we're very fortunate to benefit from Julie's extensive experience integrating patient perspectives to improve healthcare systems capacity, quality, and efficiency for common mental health concerns like suicidality, depression, and substance use. And Julie's adept at identifying appropriate quantitative methods to discover health services patterns in really large administrative data sets and pragmatic trials with the goals of optimizing care delivery and improving clinical practice. In addition to that, Julie also uses qualitative approaches to help generate new hypotheses and really direct attention to the key questions that matter to those who provide and receive care. So with so many strengths, we're lucky to learn from Julie's experience and engagement with partners, as well as her extensive work with Kaiser Permanente and the Mental Health Research Network. And with that, Julie, I'll turn it to you for your presentation. Thank
Awesome. Thank you, Molly. That was so nice.
you.
I always feel like I want my teenage daughter to hear my intros, just so every once in a while. um, anyway, okay, I'm gonna jump right in.
Like for Christmas this year, you get a 5-minute video of all of the ways that people have introduced me. I am valued and respected in my work.
Totally. Okay, so I'm going to be talking about Epic integration and point of care decision support for suicide care today. So just a disclaimer, I put this presentation together. I presented this content quite a bit, but I haven't ever presented it this way. And I also put it together a little quicker than I had planned because Anna and I switched months so she could be at the PCORI meeting this month today. So it might not be as smooth as I would have hoped, but it's all here and I'm looking forward to sharing it. I'm happy you guys are here. And I'm really grateful to be able to have the opportunity to talk a little bit about this work. So I'm going to be talking about a couple different projects, one success, one failure. And I'll get into the details about that in a second. But first, I want to acknowledge I couldn't do this work without a lot of people. I'm definitely not doing what I do alone. And I really want to call out specifically the people who both provide and receive care at Kaiser Permanente, Washington. A little bit more about me by way of positionality. I'm, as Molly mentioned, passionate about collaborative science and suicide prevention. I do have personal experiences with suicide loss, as many of you heard me talk about before. My mom died by suicide in 2010. She's pictured here on that slide. For that reason, I, really motivated to engage both people at risk as well as their care providers. I'm also grounding the work that I'm presenting today in sort of 3 research approaches: user-centered design, qualitative and statistical analyses, and implementation science. So you'll see some of those things as we kind of go through the work I'm describing. The key takeaways I want you to take away today are that user-centered implementation takes time and resources, which is not new news to many of you, I'm sure, but a lesson that I think we keep learning. And also, failure is an opportunity. Failure doesn't always feel great, but we learn a lot. And that's what I'm going to be talking about in the second project I'm going to talk about. I should have also mentioned, feel free to pop questions in the chat. I can't see those right now, but feel free to call those out, especially if they're clarifying questions. As I'm describing things, and I'll take a pause too, just in case people have things they want to discuss or comment on.
Julie, I'll monitor the chat for you and jump in as appropriate.
Love it. Thank you, Bali. All right. So just again, by way of background, why are we addressing suicide in healthcare? Well, we know that people often see a healthcare provider prior to suicide attempt. So we have potentially opportunities in that setting to prevent suicide deaths and attempts. Asking patients about suicidal thoughts is becoming more common, particularly because these questions are often included in commonly used depression assessments like the PHQ-9 many of us are familiar with. Last, I want to mention, I'm going to come back to this last point in the second part of this presentation. At-risk patients don't always report suicidal thoughts for a variety of reasons. There was a paper I'm referencing here, a few colleagues and I did quite a few years ago now, where we interviewed suicide attempt survivors relatively recently after they had reported having no suicidal thoughts, to understand a little bit more about that. And we learned some interesting things that we continue to apply to the work I'm going to be describing today. I also just want to ground us in the zero suicide framework. Many of you are probably familiar, but it defines sort of 4 key functions of clinical practices designed to prevent suicide attempt. So I'm going to be mostly focused on identification. I'm going to try to get my little laser pointer here. Most of the things I'm going to be talking about today fall into this identification bucket and an engagement. So I'm going to be talking a little bit about screening and assessment, and also in the second part, suicide risk prediction algorithms. I'm also going to be talking about safety planning. So that is that, and then we'll jump in. So the first project I'm going to talk about is integrating suicide care and primary care. So this is the success. This is the folks that contributed to this project in different ways. We had some funding from the National Institute of Mental Health and the Agency for Healthcare Research and Quality. This is the paper that was published a few weeks ago. In case you want more details, I want to just put this here front and center. But what integrated mental health was at Kaiser Permanente, Washington, was originally designed to focus on alcohol use, because that's what we had funding to do. But at the request of clinical leadership, they wanted us to add depression, suicide risk, cannabis, and other drug use. So I'm mostly going to be focused on what we did for suicide risk today, but I wanted you to know that it was kind of like a part of a bigger package. We had 3 implementation strategies that we used to implement this work: practice coaching, clinical decision support. So this is the focus of my talk, but it was part of a bigger package. So I wanted you to see how it was integrated into this bigger package, and also performance monitoring and feedback. Here's the original cluster randomized implementation trial paper published last year. Amy Lee is the main author on that. So in case people have questions, the original paper is here. So practice coaches were really the centerpiece of what we implemented. So the coaches were interfacing with clinical teams that we rolled out this work in each one of our primary care clinics at Kaiser Permanente, Washington. They were interfacing with our leadership team, as well as the electronic health record tool team. I was also a member of this team, and I'm going to get into what the details were here. So coaches this team was meeting weekly over the few years of this project. So it wasn't for a short period of time. It was a long relationship we had. We were improving and building electronic health record tools. We were identifying breaks, and that's why what I talked about before, just a slide back here, was so critical, like this link to the clinical teams. We were identifying breaks. We were aligning the tools with the workflow, and I'm going to show you that workflow in just a minute. And we were also harmonizing tools across the system. So though we were focused on primary care, we really wanted to align what we were doing with mental health and urgent care. Kaiser doesn't have inpatient care in the state of Washington. So these are kind of the main areas where we were focused on aligning suicide care across our system. So this is what the workflow looked like. This is what had
Julie, can I jump in with a
yeah,
quick question?
yeah, please do.
Who were these coaches? Were they like other clinicians? Like what was their background
Yeah,
and role?
yeah. Great question. So the coaches were we had three coaches. They had different backgrounds. One of them was a psychologist, one of them was a ARNP, and one was a public health researcher. All of them had so they had content expertise, so they knew, like, they had been trained in evidence-based practices for substance use and alcohol use specifically, and also specifically, like, their main role was to take what they had. Let me just go back to this slide because it helps me remember. So, like, the main thing that coaches were doing, and I'll get into this and I'll talk about like over what time period in a few slides, but they were mainly working with clinical teams, like validating concerns, trying to like fix things in real time, right? Address like some of the concerns that were coming up over the course of this implementation in real time. So that was really their main expertise, was like having some content expertise about what we were implementing, but also being trained in practice facilitation. And I think there's some trainings, like the VA has a training in practice facilitation to really, I think, just the main thing is to take a different approach, not like the top-down approach that a lot of us are really used to in healthcare systems. Like, this is just what we're going to do and this is how we're going to do it, but really to understand like what clinicians or what clinical teams needed, and feed that back. Any other follow-up questions?
That was super helpful. Thank you.
Okay, cool. I can get more into that too in our discussion time if people are interested. And that's part of some of the methods papers that we have out there as well. So the workflow that was implemented in each clinic was this. This is kind of the bigger picture, but I'm going to step through some of the clinical decision support in a second that supported this workflow. So patients were coming in annually to their primary care clinics, or when they came in and they had been identified as not being screened, they were screened at least annually for depression, alcohol use, and other substance use, cannabis and other substance use. So part of that there was a 7-item screener. I'll show you in the next slide, or 2 slides, I think. Included the PHQ-2, followed by the PHQ-9 when patients screened positive. That 9th question asks about thoughts you'd be better off dead or hurting yourself in some way. When patients answered they were having those thoughts more than half the days or nearly every day, there was a prompt to do the Columbia, a brief self-administered version of the Columbia that was on paper at the time, because this was pre-COVID that we implemented this work. If patients indicated they were having prior month intent or planning for suicide attempt, so this is basically answering yes to anything higher than question 3, then they were engaged in same-day safety planning, and then with an integrated mental health social worker who was based in that clinic, actually in person at the time this was implemented. Again, some of this has been converted to virtual support in the post-COVID era. But this is overall, I just wanted to give you a sense of what the workflow looked like. And then I'm going to step through some of the details. So here's a picture of the annual screening prompt. Since I'm supposed to be talking about clinical decision support tools, I wanted to give you guys some pictures of what we implemented. This is definitely not everything, but this is just kind of like a little bit of some of the important things. So this was for check-in staff. They use what's called a DAR. We laughed a lot because it was called the DAR for PARS, and I don't know, for some reason that really made us laugh a lot at one of our meetings. There was a red dot in this column that basically indicated when adult patients were due for annual screening. That's what they saw. For medical assistant and primary care provider dyads, they had a due for screening, behavioral health related screening prompt in the health maintenance needs. So those were couple of the prompts, like the pre-visit prompts. This is what the screening flow sheet looked like. So patients were receiving these questions on paper, but they were entered into Epic Flow as they were being roomed. So here's the PHQ-2, and then these were the additional 7 questions. The Audit C, 3 questions about alcohol use. There's a question about cannabis use frequency and frequency of other illegal drug use or non-medical use of prescription medications. When patients, again, indicated they were having relatively frequent suicidal thoughts, they were prompted to do the Columbia. That was on that was an additional sheet of paper that the medical assistants could hand to patients when they scored a 2 or 3 on that 9th question, the PHQ-9. Again, now this is all being done in virtual questionnaires. It continues to be done on paper, though, too, when patients don't complete it prior to their visit. So this is the picture of what the Columbia looked like in Epic Flow that we built. There was a best practice advisory that prompted safety planning when patients scored basically a 3 or higher on this version of the Columbia. We called it a crisis response plan at the time we rolled this out because that's the language that our clinical leadership preferred. Now we call it a safety plan. But basically, it's the Stanley Brown version of the safety plan. We added some additional information to step number 6. But there are smart text, smart lists that are part of this safety plan that we built, which is built as a smart phrase, a system-level smart phrase that clinicians could use to kind of more easily select from lists of, common warning signs, strategies for like coping strategies and other things that are part of those 6 steps. And also we integrated Lock to Live in step number 6, but that came later. This is a perfect picture of the performance monitoring and feedback reports, one of the reports. So that was, again, the kind of the 3rd implementation strategy we used. But this strategy wouldn't have been possible without the clinical decision support tools that we implemented in Epic. So we pulled, screening rates, assessment rates for depression and suicidality, as well as substance use, and fed those back to clinics regularly. There was a lot of other reports, but this was kind of the high-level report that clinical leadership received. Oh, I love the dog barking in the background. I was like going to try to tie that into the presentation somehow, but I won't do that. Okay, so how do we know it was successful? Before I get into the project that failed, I just want to briefly tell you about how we know that this was a success. So we evaluated this work using a stepped wedge design. Clinics were randomized to 7 waves of implementation. We also did a pilot that wasn't included as part of the 7 waves of clinics that were randomized. During this pilot, it was when we actually did a lot of clinical decision support building. So I just want to call that out here. We used a stepped wedge evaluation, stepped wedge design. So the usual care period included the first kind of 2 months that coaches were working with clinics. So this is when they were piloting some of the work, preparing, they were doing some trainings, they were really working with a small team of people to make sure that like what we were implementing was working with their workflow in each clinic. Because each clinic had, different staff, slightly different things, slight differences in the way that they did things. Then clinics had a randomly assigned launch date, and this is when the electronic health record prompts were turned on for all adult primary care patients. So that's when that annual screening prompt was turned on. And the intervention period included 4 additional months when coaches were working with these clinical teams every 1 to 2 weeks. So again, there was quite a bit of effort that went into meeting with teams. So I won't get in a lot into the methods. There's more in the paper, but I will briefly just talk about the results. In the usual care period, we had about 255,000 patients with about 950,000 visits. In the integrated mental health period, we had 228 with about 600,000 visits. Broadly, the populations were similar in the usual care and the integrated mental health period. I won't show you all the demographics, but here I include age and sex. There's more in this paper. In terms of risk identification, these results are presented in terms of per 10,000 patient visits, which isn't the way we like think about things, but we did this for like so that we could compare at the population level in the usual care versus integrated mental health period. So we can see that screening rates are quite a bit higher, right? So a lot more people are receiving the PHQ-2. So it goes from 2,900 per 10,000 patient visits to 8,200 per 10,000 patient visits. And then you can see kind of how that cascades down into the numbers of patients that are reporting prior month intent or planning for a suicide attempt on the Columbia here in that bottom row. In terms of engagement and treatment, here is our main outcomes that we present in that paper. We saw a 14% increase in safety planning. So again, these rates are per 10,000 patient visits, but we include a percentage here because that's a little easier, I think, to wrap our heads around. We saw a slight decrease in new psychotherapy. That wasn't like a main outcome, but this is just something that we measured. So it was kind of interesting, like not a huge decrease, but it was, statistically significant, potentially because patients were receiving what they needed at the time of the primary care visit. But we don't know for sure. And then this is the exciting finding that we found, a 25% decrease in documented suicide attempts in the medical records. So this is when patients were being medically treated for a suicide attempt. We used combination of claims data and electronic health record data from our system. So we saw a 25% decrease in documented suicide attempts within 90 days of a primary care visit. We also looked at 30 and 60, but the 90 was our main outcome. So I'm going to pause there just briefly before I jump into the failure project. But I wanted you to see the success first, and then I'll get into the failure. So are there any questions, comments? I'm just taking a look at the time too to make sure, see how we're doing.
I don't see anything in the chat, but people can unmute if they have a question.
Cool.
I had one question.
Yeah.
Can you go back one slide?
Yeah, sure.
So this decrease here, do you think, because this is only for documented suicide attempts and not necessarily why, I answered my own question in trying to formulate exactly what I was going to ask. So never mind.
So limitation is that, something that we've talked about before, Lucas, and I don't know if this is where you're going, but we don't know, like this isn't going to align exactly with what's happening in people's lives, right? So this is medically, like suicide attempts that are documenting in medical records. So we know from other work that probably there's a lot of untreated suicide attempts that are happening in people's lives as well. We're only capturing what we can see in the medical record.
Yeah.
Any other comments, questions before I move on? It's going to pause for a few more seconds here. Okay, I'm going to keep going. So the next project I want to tell you about is implementation of suicide risk prediction analytics to support suicide prevention. And this was our failure. So I'm excited to tell you about this. This was our team of people that I worked with. We had some internal funding as well as funding from the National Institute of Mental Health to support the work I'm about to share with you. A little bit more about the background of the failure. So the Mental Health Research Network is considered to be a leader in algorithm development and testing. So Trevor presented on this a couple months ago, but Greg Simon and team published this paper. I can't see the date on my small screen. Okay, 2018. This development of this. There was actually more than one algorithm, but the algorithm I'm going to be talking about predicts suicide attempts in the 90 days following an outpatient mental health visit. So they published this original paper in 2018. Since then, there's been a lot of other papers they've published, and this has been validated in other systems. I'm not going to get into that today, but if you're interested, just reach out. Let me know. I'm happy to give you a list of papers that the team has developed. what I want to talk about is implementation. So Kaiser Washington piloted and evaluated the first implementation of an encounter-based suicide risk prediction algorithm. So Reach Vet, some of you guys might be familiar with that. So the VA is another leader in this area, right? They've been doing this work longer than Kaiser has. Reach Vet, though, is designed to identify people and do outreach to vets who might be needing some additional care. So it's designed in a different way. So when I say encounter-based, this means like at the time patients were being seen. So we're trying to implement additional work to augment suicide prevention at the point of care in mental health specialties. So we evaluated that work. So the encounter-based flag did not consistently prompt additional suicide risk assessment as intended. I'm going to tell you, get into more details about that, but that's what this paper says. This is a paper we published in 2022. But it also provided a roadmap for improving what we did next. So I will get into that as well. So that's the kind of the exciting part. That's the good news. First, I want to tell you about the failure. So this is the recap. So you saw this picture before. This is what we implemented in primary care later on, but this was already happening in mental health specialty. So the existing clinical workflow is the PHQ-9, followed by the Columbia, followed by safety planning. So what the original prompt was designed to do was to flag patients identified at high risk of suicide, which was in the top 5% of estimated suicide risk, and prompt the Columbia to be completed, this brief self-administered version of the Columbia, regardless of what patients reported on the PHQ-9. It was also designed to use very minimal resources. So you'll see how that in the next slide. But this is what the behavior was that we were intending to prompt with this first rollout. So there was one pre-implementation meeting in October of 2019. The go live date was a month later. There was one clinic that piloted this work, the mental health specialty clinic on Capitol Hill. This is what it looked like. So the prompt was an additional column that was added to clinician's schedule with a little yes, a little Y, if the column needs risk assess was populated. So that's what it was. It was designed to be minimal resources. Clinicians basically were instructed on how to pull this column into their schedule and use it as part of this pre-implementation meeting. So how do we know it failed? Well, we did a mixed methods evaluation. We stopped it when everything shut down in March of 2020. So we had at that time, we had 161 visits with a flag. So these were, again, visits that were flagged at the top 5% of suicide risk in the 90 days following that outpatient mental health visit. So what we saw is that only 13% of patients who had a flag but did not report suicidal ideation on the PHQ-9 completed a suicide risk assessment. So that's how we know it failed. The good news was that the existing workflow continued to work, right? So patients were being assessed when they reported suicidal ideation, relatively frequent suicidal ideation on the PHQ-9. We also did some semi-structured interviews. This was part of a bigger project that included 2 other healthcare systems. We talked to clinicians and to patients. But really the clinician interviews were, I think, the most important for understanding what we could do next. But the patient interviews were really important for understanding sort of some broader contextual concerns that continue to inform the work we're doing now. But I want to read you a few quotes. So here's one around lack of follow-up after implementation. So let me just find my little, let's see. Do I have to stop sharing? I can't move. I have some of the quotes here, but for some reason I can't get to them. Let me see why. Okay, wait, maybe is that working now? All right, sorry guys. All right, I'm moving my pictures down here. Okay. I don't remember too many conversations about this in our clinic, seeing how it was working for people, how folks were dealing with it. Was it improving anything? I think this might be one of those things that is helpful just at a clinic level, after things like this. And that happens a lot. just after things like this are implemented, like not to just call it good, like to check in with folks, especially since I know we've had at least one or not two new hires since then. So another thing that came up was patients at risk without a flag. The people who have this flag. So I'm like, okay, that makes sense. They have the flag. But I guess my bigger concern or question would be some of the people who should have flags that don't have flags. And then we saw some concerns around reliability and accuracy. I think reliability is a big question. Knowing what's happening on the back end would be helpful. So I just wanted to read a few quotes that we had. Some things that were important contextually that continue to be important were that we heard a lot of concerns around potential liability and responsibility for patient safety. This is the little arrows going out is supposed to show like how the interviews diverged. So patients here were on the flip side, we're reporting fears of coercive care, anticipated stigma, or differential treatment. So anyway, I just want to highlight that contextual concern as well. All right, now that I moved my pictures, I need to move them back so we can go to the next slide. Okay, here we go. So this is what we did next. So we engaged a small team in user-centered design. We used the DDBT framework. So you guys will probably be familiar with that since we're using it like to guide the SCRC work. And we, at the end, we conducted a small usability survey to inform next steps. So I will talk about that. I'm just going to do a quick time check, 9:33. Great. So this is what our activities looked like. I won't step through all of these, but I will show you that in our discover phase, we did some workflow mapping because things had changed a lot because COVID had happened like during the time period we implemented and then when we were doing the redesign. So on this side, we were trying to understand what was happening in the medical record. So in Health Connect, our version of Epic, like when patients were receiving these questionnaires virtually, what was happening after that, how clinicians were interfacing with that at the time of their visit. So this is kind of a simplified version of our workflow mapping, but we're trying to figure out, was helpful for us figuring out like what we did next. And I'll show you that. So the key change, we revised our implementation to support adoption of this new risk flag. So we used it in terms of the workflow integration, we focused on safety planning instead of additional risk assessment. And that was for a couple reasons. One was because clinicians mentioned that they didn't want to spend their extra time doing more assessment during these visits, but really they would rather just go straight to safety planning. So that was part of it. We also know from the beginning of this presentation, when I talked about how patients often don't report suicidality when they come in for visits. So that was another thing that we were thinking about when we decided to move towards prompting safety planning instead of additional assessment. And we did our tools in a different way. I'm going to show you the picture of the new tool in a second to address the clinician concerns about kind of how clunky it was to have to pull in their own stuff. So anyway, there were some things that we did to improve that. We took that's why that qualitative feedback we got was so helpful. And then we developed some new clinical resources to support the use of these tools. So these are just an example of some of the things we developed. So there was this tip sheet that we had with pictures, and we did a huddle. We had a huddle card, and we distributed this huddle card in a variety of different ways at small team meetings across the system using kind of routine communication strategies. Like we have an Epic newsletter that goes out. So those are a couple ways we disseminated these tools. This is what they looked like though. So this again is the focus of my presentation today. So I wanted to make sure you guys saw a screenshot. If you guys see any names here too, this is all fake data. So there's no like real information in here. So you can see here, when clinicians open up charts now of patients who are identified in the top 5% of suicide risk, they see this, and this is on the progress monitoring tool tab. But one of the like modification targets we identified was clinicians really wanted to see this at the beginning of a visit. And a lot of the tools like BPAs aren't like, they're set up to fire after like clinicians do things. So it was really important for us to identify like the function of what we wanted to modify before we like jumped into like what tool it was that we wanted to develop. So related to transparency. Like we wanted to make sure that we were describing why we wanted patients to create or review a safety plan with a patient because they were identified in the top 5% of suicide risk in the 90 days following this encounter. And they could link to the huddle card directly from Epic. We also integrated this suicide risk flag, I'll call it, on the storyboard. And if you hover over it, then clinicians could see like why they were identified at risk. So we don't have individual level risk, but we did include some information about like the strongest predictors, which included self-harm, included prior suicide attempts, prior inpatient or emergency mental health care, mental health or substance use disorder diagnosis, and endorsing thoughts about item 9 on the PHQ-9. So I didn't get into this when I opened, but what risk prediction algorithms do is combine all of these things together and give people a scaled level of risk. But these are kind of like the top predictors that come up for people. So we wanted to give clinicians a little bit more information about that too. So that's what that looked like. And then I'll just cover the usability survey. So we had 51 mental health clinicians that answered qualitative and quantitative questions about how they use that flag, whether and how. So we saw that we had a decent amount of people agreeing with the fact that they found the flag useful, but still some work to do here, right? So a fair amount of people still either were neutral or disagreed or strongly disagreed. And similarly with whether or not they always created or updated the safety plans when the patients had a suicide risk flag in their charts. A couple quotes here. The first one says, "It's nice to have it there as a reminder, but usually it shows up for patients who are already focusing on crisis planning. It seems like a good practice to have it there anyway." Another said, "The safety plan is not needed much of the time as it already exists and has been updated recently. Then patients with chronic suicidal ideation are common." So back to the key takeaways that I started with. User-centered implementation takes time and resources, but failure is an opportunity. So we saw that in our second project. And I will mention that we continue to use what we did here in a new grant that I have focused on implementing risk prediction to support suicide care in primary care. But as you might guess, the considerations for how you do that work is quite a bit different in mental health specialty settings versus primary care. But that's all I've got for you today. So I just want to stop there. This is a picture I took very recently from the 75th floor of the Columbia Tower downtown, which I'd never been to, so it was kind of cool. But that's it. That's all I've got. Oops, yeah, in slideshow. Now where are my pictures? Here we go.
Awesome. Thanks so much, Julie, for highlighting those two projects. Pat has a comment in the chat. Pat, do you want to unmute and share your thoughts about the flagging?
Oh, yes, I don't have too much more to share, but it comes up against one of the issues that I've run into with my research of, okay, if certain group is not getting flagged when they should be and another group is, obviously getting flagged properly, there's a question of like what characteristics of the patients correlate with sort of inappropriately being missed. So that was just a thought that I had based on some of my prior experience.
Yeah, good, great question, Pat. No, thanks for calling that out. So there's a couple thoughts I'll share. So one, like at the algorithm development level, they've done some work looking at whether or not how the flag, and this is actually the topic of an existing grant as well that Yates Coley has. They are evaluating, if the flag, whether and how the flag might be exacerbating health disparities. So what Yates found. So there's a flag that I didn't talk about that flags people at risk of suicide death, and they did see some disparities, particularly like among people that were missed. From my memory, I believe that it was higher rates of Black patients and Hispanic or Latin patients. So that's I'm quoting that, but it would be better to look at Yates' papers. So we know that at the algorithm development level, like there continues to be need to be work in this area. Like what we're supposed to be doing as part of the work that I have now is trying to understand like also implement like health equity implications when you go to implement this work, right? So we know that like having like suicide risk potential like in your chart could lead to differential treatment, and there we don't know like how that may or may not translate into exacerbating like disparities, or so the goal is to get people care that like supportive care they might need, but we know that these things that when we implement them they can also they're not always used the way that we intend. So we're trying to understand like how to evaluate that. I don't know. That might not be exactly getting at your question because you were talking more about like people that the flag was missing. And I think that's really an important part of this bigger picture, who it's missing. Like we know that it mostly misses people that don't receive care in the system. And we know that people that are not receiving care in the system tend to be people that like what do I want to say here? I'm probably talking too much about this topic, but it's been something that's been on my mind a lot because I'm trying to figure out how to write about it. So there was a master's student who did some work really recently who looked at Black youth. She really wanted to understand suicide care disparities among Black youth. When we looked at visit level information, we saw that Black youth were being screened at the same rate as white youth. But then when we look and reporting suicidal ideation at the same rate as white youth, this is just a master's thesis, but it was really interesting for me to think about some of these issues. What we saw though at the population level is that white youth were being screened at much higher rates than Black youth. When you look at everybody that Kaiser's responsible for, we don't know why that is, but it's likely that Black youth are less likely to have kind of annual screening visits. So that could be for a variety of reasons, right? Related to, historical racism and like maybe not finding the care helpful. So like there are different interventions that you have to think about there. Anyway, it's a topic on my mind. Thank you for bringing it up. I'm going to stop talking there. Blah, blah,
Thank
blah.
you.
Yeah. I'd love to talk more about it too, by the way, Pat, if you have thoughts about this. Like, if you've been thinking about this too, I would love to have another conversation about it.
Thank you. Absolutely.
Trevor, did you want to talk about your question?
Oh, sure. And with the caveat that I have a dog in a cone here after a procedure who might want to participate in my question answer. But so the first question was around the role of presenting features. Like I saw that explanation of the top 5 most predictive features, which, I think we typically think is important, right? To give clinicians the opportunity to decide whether or not to trust an assessment from a predictive model. And I was wondering if you'd had any feedback about that component, particularly if it was perceived as something valuable or if you think it might have had a role in adoption.
Yeah, I feel like we need to get more information about that, Trevor. Like that's a really good point that you make. So we know that what clinicians really wanted was like individual level risk factors. We know that they wanted to know like like does this person, why is this person being flagged, and like have like specific risk factors. But because we were pulling this information from claims, it's not easy and we're combining it with information that's in the medical record data. So a lot of the care, like suicide attempts are like a lot of the information we have about suicide attempts are coming from outside of our system. They're coming from hospitals, and we receive claims for that, for care received for that attempt. So that's how we know like when that's happening. So it was kind of a we wanted to provide a little bit more transparency, but we couldn't provide like individual level risk easily. So like that's something I think we should keep working towards because we know that's what clinicians want. But so this was kind of like, this is what we can do now to at least give clinicians like an understanding of why everybody like how this algorithm calculates risk. So I don't know, but that's a good call out that you make. I think we could keep making that more useful and see if what we did was our compromise, I guess, was useful.
Yeah, like there are a lot of potential design decisions around that, like how much information to provide, how much people will actually absorb. My other question was around the sort of redundant recommendations. Like we see this a lot with other predictive models here at UW. The patient has a sepsis alert, but everybody knew they already had sepsis. And so like I was wondering if there might be a way within Epic to build a rule that would not recommend a safety plan if one was already in place and recent, or if that would even be appropriate.
Yeah, I think we need to do that. Like we've also talked about having it like snoozed, right? Like being able to snooze the alert to or something, like turn it off, like you're saying it. So I think if the so what's happening is the algorithm is right now is being updated monthly. So it's not daily. Some systems are like now that some more systems are doing this, they're updating it more frequently. We know that patients' risk doesn't change necessarily like on a daily basis, but patients do come off. Like they will be flagged for like, I think we looked at it like 3 months was around the average period of time. So if a patient hasn't had a safety plan, updated within like a month, we might want to like these are decisions that there's not a lot of evidence to guide, but like I think it's more clinical experience that like maybe you're calling out, Trevor, that would be helpful to get, right? Like to understand like how often it's useful to update a safety plan, especially when there's competing priorities at those visits. And we really want those visits to be patient centered too, right? So we want clinicians to be able to address what their patients want to talk about. So anyway, that's kind of gets part.
Thanks.
Yeah, thank you. I appreciate the suggestion and comment. Keep taking a look at the chat here. I see more from Pat. Pat, do you want to say out loud what you were thinking about?
Yes, sorry, don't mean to talk a lot during this meeting. But just one thought I had that I was directing at Julie and Trevor mainly, but I've always been curious with predictive modeling in a clinical setting of it might be worth training the models more on cases that clinicians miss. And that might reduce the amount of sort of alerts that come up that a clinician would normally catch. So I wonder if to some degree it's an issue at the level of the training data. Like we're looking at overall accuracy when maybe what we should be looking at is accuracy in the subset of cases that are difficult to catch.
Yeah. Yeah, that's a great suggestion at the algorithm development level. I think we're trying to figure out how to do that at the implementation level, right? So we're trying to figure out like kind of like speaking to Trevor's point, right? Trying to flag when patients are not, and that's what the VA does with ReachVet too. So they'll review charts and see if a patient's already sort of like receiving care, and then focus on the ones that like perhaps aren't, right? Like that are not engaged in care, who might need more resources. So I mean that gets sort of partially at what you're saying, I think. So my focus has mostly been on the implementation level, but I think you're speaking more to like algorithm development, which is a really useful point. And I'll bring that up with the people who do that work.
Yeah, Pat, there's some work I've come across, but I couldn't find in the time, you asked the question by Eric Horvitz, where like when he talks about it, it's like the idea is to give clinicians things they might be surprised by. So the model will predict things that it thinks that are not known that would be surprising to the person in the context of their own assessment. But I haven't been able to dig it up yet. But I think it speaks to what you're driving at here.
I'd love to see that paper actually.
Ian, do you want not to switch gears off of the algorithm development part, but do you want to say a little bit more about the safety planning like app that you're describing?
Yeah, I mean, so first of all, I want to apologize for traveling. I'm in Reagan Airport. So can you guys hear me okay?
Yeah, we can hear you. It's a little jumbled, but I can hear you.
Yeah, and I'm in the midst of a lounge, so I'll be a little bit limited. So, there just seems to be from a primary care provider's perspective, how you manage, you were talking about getting like a monthly safety plan update, how exactly the clinical team manages that, so that it's efficient and is user friendly and doesn't and is done with some regularity. That you would hope, at least I would hope as a primary care provider, that I'd have help with that. Through some kind of integrated behavioral health team, and that would be potentially, at least what we're thinking about with some of the stuff they're doing with monitoring the Ampere project. That feels like something that is more user centered. That there's a tool that is asynchronous, and people think about it and respond. Yeah, I think I should update my safety plan because I'm talking about the patients now, because I feel like that's an important thing to do. I think that those sorts of add-ons would be, important as part of an overall strategy for supporting people going forward.
Yeah, I love that. Thank you. Thank you. So that's going to be really useful. I appreciate that comment, and I might hit you up to learn more about Ampere too, because that's like going to be super relevant to the work that we're doing in primary care. And we know that like the design considerations for that environment are much different, particularly because patients are often seen in person. They can often see the screen too of like when you're in a primary care appointment. So probably having a suicide risk flag isn't going to be the best like design for that audience, and also prompting safety planning and like doing that in a way that's both supports like the therapeutic alliance and all, but within the time that primary care providers have to work with their patients, which isn't usually like the amount of time that it takes to develop a good safety plan, right? Like at like 15 minutes, probably you need a minimum of 20 for safety planning, right? Like, and that's like patients aren't coming in for safety planning, so like that's where the integrated like care is really useful that I talked about before. But I love the idea about using technology to support like the usefulness of those tools. Are there other, Andrea, I see you have a comment here. I know it might be like going back to the modeling. You want to talk about that?
Yeah, I think we came back from the modeling. Oh, this is interesting. It made me think of signal detection theory when we started to talk about Eric Horvitz. I know nothing on modeling, so.
Yeah, but do you want to say something about signal detection? I don't know about that, so tell me what.
It's just it's old school modeling on attention, and like thinking that it might be interesting to just look at that in terms of alerts where people are attending to and not, to try to get at what Pat brought up. I thought was a really interesting strategy.
Cool.
It'd be fun to watch what people do with it, but that's not my area. And
Gotcha.
I also thought was really great to illustrate that failure is not a failure. It's thank you for sharing this story. It's an opportunity to pause and take a deeper look and adjust and come out on the other side in a better position. So I think it's a great example, and I'm really glad that you pointed that out for all of us.
Thanks, Andrea. I will say, like, I feel like we all fail, right? I mean, it's like, and we learn a lot from those things. I also don't know how often people describe it though in NIH grants, like, because I wrote about the failure in my R34 and I got a lot of comments like, I mean, which was eventually funded. So that's the good news, but a lot of comments like, well, if this failed, why do you want to do it in primary care? And that wasn't really like the point, but it was interesting. So when you write about failure, I think you have to be really intentional about like writing about how you're using the information or something, right? Like, but yeah, normalizing, I think it would be good for all of us to normalize failure a little bit more in our work. And thank you for the comment about signal detection. I'm gonna like follow up on that. That seems really important. My to-do list includes a consult with you on Ampere. Great. Love it, Ian. All right. Any other, I know we're getting close to the end of the hour, but want to make sure if people have other comments or questions to jump in.
I had just a small question on the build, the like storyboard reminder. Did that dynamically change at all, or was it always red and just on the side?
It's was always red and on the side. I think,
Okay.
you mean like, can so it turns on and turns off based on when the algorithm gets updated monthly. So like it'll go off somebody's storyboard if patients are no longer identified at high risk of suicide. So like, because the algorithm is getting run monthly, some of the things that put people at risk sort of like time out, so there is like some time factors that are included in the algorithm development. So if a patient had a more recent suicide attempt, for example, that puts them at like a higher risk of their puts them at higher risk. So like that risk is gonna like go down over time. I don't know. I don't know if that's what your question was about, but yeah, it's once it was on, it stayed the same, but then it could come off.
Yeah, I think my question was also like kind of also getting at some of the things that you touched on of like potentially being able to like snooze that or like have a different color if the safety plan had been made, but still want to be aware that that patient was indicated at risk. So yeah, that was helpful. Thank you.
I like the idea about it changing color. Like that would be cool, actually. Like thanks for bringing that up. Like it's like all these suggestions are super helpful for thinking about next steps.
Yeah, like if it went from red, like safety plan has not been done, to like a yellow, like safety plan has been done, but the patient is still identified at risk. It's still there, but it's not as at least not as visually like red alert on the left hand side.
Yeah, I know. Like I struggled with that a little bit. Like so our co-design team was like, you got to make this like red and say suicide risk. I was like, well, maybe we should have it say something else, like maybe not make it, because I was thinking about the patient concerns about sort of overreaction and fears of coercive care. But the clinicians are like, we need something that they'll pay attention to. So, like there's these like kind of competing priorities sometimes, but I appreciate that. Like having something more dynamic, I think would get it being able to address things from both the patient and the clinician perspective. So yeah, that's a good call out.
Could you also speak maybe just briefly about getting permission to add something to the storyboard? Because I've always heard that that's something that's incredibly hard to do. So like, how did you navigate the administrative bureaucracy structures to make that happen?
Yeah. So the deal with the storyboard is you can do it like at the like department level. So you don't have to change the storyboard for the whole system. You can also do it at like you can like the storyboard is incredibly like you can change it for different types of clinicians. So that's the nice thing about the storyboard. So you don't have to we didn't get permission to change it at the system level. Only mental health providers see this, not primary care providers currently, which is like how we intended it. Because we think that probably we won't do this for primary care based on the feedback that some subsequent qualitative work we've been doing. So yeah, but good call out. Yeah, it's like we worked with mental health leaders to do it. So they're the ones who said go ahead and do it. But we only had to do it with mental health leaders. We didn't have to do it for like primary. Getting permission to do something for primary care on the storyboard is a whole different thing. Yeah, good call out. I see we're at 10 o'clock, so we'll go ahead and wrap up. But I, again, really appreciate everybody's time. Thank you for being here today. It was great to have the opportunity to share about this work.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.